First of all, thank you to the organizers for inviting me to this meeting. This is my first meeting with patients and with advocates of patients. My talk, I think that was the first of this part, and my goal was to explain in a very simplified way, as I usually do to my patients, what is an MPN and what types are. These are my disclosures. So what are the main features of MPNs? These are, I usually start explaining to the patient that these are chronic diseases. They are not an acute leukemia. They are characterized by excess production of myeloid cells, that's red blood cells, white blood cells, platelets. These diseases have an increased risk of vascular complications, mainly thrombosis and bleeding. The diseases have a good survival, years, but they are slightly decreased. And finally, these diseases may impair quality of life. In most cases, but usually patients don't feel extremely ill. These are the WHO classification of myeloproliferative neoplasm, and basically they group chronic myeloid leukemia and what clinicians call classic MPNs, that's Phe negative, that include polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Let's have some views about the historical milestones in CML. In CML, in 1960, Noel and Hungerford discovered a minute chromosome that called Philadelphia chromosome. And later, Janet Rowley, in 1973, reported that this chromosome Philadelphia, called in this way, was a translocation between chromosome 9 and chromosome 22. Later, it was known that this translocation involved some segments, some molecular segments, BCR, ABL, and fortunately, in 1996, Brian Drucker started the clinical trials of treating CML patients with an inhibitor, a selective inhibitor of the oncogene imatinib. Now, what are the milestones in the conceptual understanding of Phe negative MPN? So what we call ET, PV, and PMF. In the last 19th century and in the first part of the 20th century, there were descriptions of the diseases by several doctors, but the main point, the crucial point, was in 1951 by William Damashek, an American doctor, who had the merit to group all these classical Phe negative diseases, PV, ET, and PMF, under the same concept, because he thought that they share similarities in clinical behavior and in clinical and in laboratory findings. Later, in the decade of 1980s, Fialkov demonstrated the clonal origin, that's the origin in a mother stem cells of these diseases. And there was really a gap until 2005 when 5 independent groups reported the JAK2 mutation. That's the link that probably William Damashek thought that was the common pathway to all these diseases. And the WHO organization organized all the diagnostic criteria from 2001 to 2016, the last edition of the classification of myeloid disorders. So a more detailed definition of an MPN. Biological features. As I have mentioned, they are clonal stem cell diseases. They are characterized by overproduction in bone marrow of one or more mature cell types. They present molecular abnormalities in 80-90% of patients with the 3 main genes involved, JAK2, calreticulin, and IMPOL. These genes are called driver genes. And the clinical features, the median age of presentation is around 50-60 years, But there is a significant proportion of young patients, especially in ET patients. Approximately 15 to 20% of all ET patients are below 40 years. This is very important, and given that there is a female predominance, pregnancy is not so uncommon in ET patients. There is a familial clustering, potential to transform, as Dr. Mesa has mentioned, to myelofibrosis and acute leukemia, vascular complications. These are diseases that are managed in an outpatient basis, and luckily we have new appearing targeted therapies. Now in the next slides, I will describe the main features, the main clinical features of each one of these classic MPNs. ET. It is the most frequent of the three. The median age at diagnosis is 60 years, but there is this cluster of young patients below 40 years. There is a clear female predominance, and splenomegaly is not a prominent feature of the disease. Less than 10% of patients present splenomegaly, increasing the size of the spleen, but usually of moderate size. One of the main and distinctive features of ET is that half, at least, of all ET patients are asymptomatic at diagnosis. So the disease is discovered through the discovery of an increased platelet count in a blood cell count. That's a blood cell count asked by the GP or by other specialists. Thrombosis is a complication, the main cause of morbidity and mortality in this disease. Arterial thrombosis is much more frequent than venous thrombosis and involves mainly the central nervous system. Bleeding is quite not so frequent as thrombosis. And one also of the distinctive clinical features of ET is what we call microvascular symptoms or vasomotor symptoms. These are symptoms that are caused by sludging of platelets in the end arterial small arteries of the brain or in other organs, and cause, for instance, headache, dizziness, anesthetic, and so on. Acute leukemia is rare in ET. According to patients diagnosed by the WHO organization, only 1% of all ET patients may evolve to acute leukemia at 10 years. In retrospective series, in all series, 3 to 4% of all patients at 5-10 years treated with hydroxyurea may develop acute leukemia. The risk, however, is higher in those patients treated with sequential chemotherapy. So, for instance, first hydroxyurea and then busulfan or radioactive phosphorus. This is a circumstance that clinicians try to avoid. Myelofibrosis is also a potential risk of the disease, but 1% at 10 years and 9% at 15 years. And a small proportion of ET patients may acquire during their clinical evolution a full phenotype of PV. PV, the median age at diagnosis is practically the same than ET. There is no gender predominance or only a slightly male predominance. Here, spleen is more prominent. 1/3 of patients at least present splenomegaly. 15 to 20% of patients are asymptomatic at diagnosis. Thrombosis also is a feature of the disease, and again, microvascular symptoms. The laboratory findings at diagnosis, these data are taken from a very large cohort from IU Teferi, based on 1,500 PV patients. One of the things that we have to take into account is that at least half of all PV patients present leukocytosis and or thrombocytosis, apart from the increase in red cells. So this is frequent. And they present 80% decrease in serum erythropoietin. Progression in clonal transformation is also a feature of the disease, and myelofibrosis is much more frequent in PV than in ET patients. Myelofibrosis. Myelofibrosis has a distinct picture from ET and PV. ET and PV are characterized by excess of production of cells, ET by platelets, PV by red blood cells and sometimes leukocytes and platelets. But here, the features of myelofibrosis are that the bone marrow is scarred, that there is scar formation in the bone marrow that may progress to really severe forms, apart from a predominance of atypical megakaryocytes. One of the features of the disease, as you know, is the huge or a big spleen that may be huge in some patients. And also the peripheral blood film shows some distinctive features that are characterized by red blood cells in the form of tears and presence of immature myeloid cells. The clinical manifestations of myelofibrosis are quite different from ET and PV. They are focused mainly on anemia. 40% of all PMF patients present anemia at the moment of diagnosis. Splenomegaly is really a very frequent feature of the disease. 90% of patients with PMF present splenomegaly at diagnosis. And also 1/3 at least present what we call constitutional symptoms. That's presence of sweating, fever, fatigue, weight loss. Apart from this, a big spleen may cause abdominal discomfort in 20% of patients at diagnosis. Thrombosis is not so frequent as it happens in PV and in ET. And there is really a combination of excess of blood cells and lack of blood cells, thrombocytosis, thrombocytopenia. How clinicians assess risk and prognosis according to the MPN type? How do we do in clinical practice? So these are the survival data of ET, PV, and PMF based on a very well-followed cohort of American patients with these three diseases. And you can see that ET has really a median survival of 20 years, practically normal, only slightly reduced. PV, a bit lower. And what also we can have to take into account is that patients of less than 60 years really live many, many, many years. The situation is quite different for PMF patients. In PMF patients, unfortunately, the median survival is around 6-7 years. But PMF, as we will see in the next slides, is very heterogeneous. So Dr. Mesa has also mentioned the interconnection of forms in MPNs, and we can see that, as I have mentioned, essential thrombocythemia small proportion evolved to polycythemia vera. ET and PV evolve in different percentage to myelofibrosis, and a small percentage of PV and ET patients may evolve to acute leukemia, especially in those patients treated with chemotherapy or with sequential chemotherapy. As a clinician, we have to consider what we call the clinically relevant endpoints. What is the most important things of each disease? And I have built this slide thinking that the endpoints are a bit different for essential thrombocythemia and polycythemia vera than for primary myelofibrosis. In ET and PV, vascular complications are the main clinically endpoint, thrombosis and or bleeding. The evolution of myelofibrosis, quality of life, of course, is very important, and survival is, in my opinion, the last important point in PV and ET, because they are long life diseases with a very long life expectancy. The situation changes for PMF. In PMF, survival is the first thing to take into account. Why? Because the median survival of these patients is shorter. Systemic symptoms, splenomegaly, anemia. So you can see that the endpoints that we try to focus when taking care of patients are quite different for ET and PV patients than for PMF patients. Dr. Mesa has also mentioned the role of molecular abnormalities. I would like only to say that molecular abnormalities allow to establish clinical correlated diagnoses. They are useful for prognostic endpoints, for thrombosis, for progression to myelofibrosis and acute leukemia, and even for survival, especially in the case of PMF. And of course, in the setting of bone marrow transplantation, assessing and monitoring the response to treatment. The molecular abnormalities has also been explained by Dr. Mesa. Just to recall that JAK2 is positive and is mutated in 50 to 60% of ET and PMF patients, and PV is a much more homogeneous disease in terms of molecular abnormalities. 95 to 97% of all PV patients present the JAK2 mutation. Calreticulin and MPL are mutations that are restricted to ET and PMF, but not to PV. And there is a small subset of patients that are very interesting, and our group is making some kind of research in this, called triple negative patients. So in these patients who lack JAK2, calreticulin, and MPL mutations. Apart from these mutations, during the last years, other mutations involving what we call epigenetic genes and other genes involved in signaling and mRNA splicing are described, are reported, and of these are some genes that are called high molecular risk genes. These genes have been named in this way because they have been demonstrated to be really prognostically detrimental, especially in PMF, in primary myelofibrosis. How we stratify the risk of thrombosis in ET and PV patients? In the same way, choosing just two clinical and easy variables, that's advanced age and history of thrombosis. This means that for a clinician, when the patient presents at least one of these two variables, the patient belongs to what we call high risk of thrombosis. And on the contrary, if the patient doesn't present any one of these, he's allocated to the low risk of thrombosis. However, this system is very useful, is very pragmatical. We use this system in clinical practice, but probably the system should be refined. And the proof is in ET, that in ET, in this cohort of 1,000 patients, when the patients were divided according to the classical risk stratification system into low risk and high risk patients, if we subdivide these low risk and high risk patients according to the presence or the absence of cardiovascular risk factors and JAK2, we can observe that the rate of thrombosis, either in the low-risk group or in the high-risk group, were quite different. So probably these are a mix. It's not an homogeneous group of patients, what we call low and high-risk patients. In fact, I think that probably in low-risk patients, 10% of these low-risk patients may be undertreated, and 30% of high-risk patients may be even overtreated. Calreticulin mutation has really been a very important finding in the molecular knowledge of essential thrombocythemia, and now we think that calreticulin mutated ET patients and JAK2 mutated patients are quite different groups in terms of risk of thrombosis and even in terms of risk of myelofibrotic transformation. But the details of that are clearly beyond the scope of this talk. Risk factors in PV. The risk factors in PV that has been related to survival, thrombosis, acute leukemia, myelofibrosis. You can see that there are several ones, especially commonly age, leukocytosis, and history of thrombosis in survival and thrombosis. And this has led to what is called the prediction of survival in a big cohort of patients, in more than 1,500 patients. These patients were subdivided, were stratified in 3 risk categories according to the presence or absence of any of these items that are in the left panel. According to this, the survival of PV patients may be quite different. However, clinicians don't use this prognostication of system for taking therapeutic decisions. These are informative, but we don't treat a patient based on this prognostic system, at least in my case. Moving to myelofibrosis. In myelofibrosis, the overall survival, as I have mentioned, is quite reduced, 6-7 years. But as you can see in the curve of survival, this is very heterogeneous. Some patients live few years, and other patients, a small subgroup, may live many years. This has led to what is called the IPSS, the International Prognostic System Score classification, that's based also in very easily variables: age more than 65 years, constitutional symptoms, anemia, more than 25,000 leukocytes, and more than 1 or more than 1% of blood blast. According to the presence or absence of any of these features, the patients are subdivided, are stratified in risk groups. This means that these patients, according to the risk group, may live theoretically 11, 8, 4, and 2 years. This has been refined by the dynamic IPS system. That's a system to be applied for patients who have been diagnosed previously. And even there is another type of stratification promoted by the Mayo Clinic that involves also platelet count, red blood cell transfusion need, and karyotype. These are refinements of the first original stratification system. And mutations. Mutations, just to give a very brief overview, mutations in PMF, some of these called epigenetic and mutation of the RNA splicing machinery may help clinicians to predict the prognosis. But usually, we don't make therapeutic decisions based on the presence or absence of these mutations unless in very individual cases. And even the combination of mutations, calreticulin, for instance, for patients with PMF who are positive for calreticulin and negative for AXL1, have a survival very higher than patients on the contrary. So the key message is that mutations, the knowledge of mutations, may help us to understand more the prognosis of PMF patients. And finally, recall the major principles and goals of treatment to make the patient feel better, to reduce the risk of future disease complications, and to improve survival. And thank you for your attention.